So welcome everybody. This is the Northern Virginia Family Practice Town Hall Series. We're very happy to be back again in 2022, and we will have a series of physicians and experts speaking with you at least once a month throughout 2022. We have a lot planned, and tonight I'm Dr. Natasha Beauvais, and my partner, Dr. Cecily Havert, is here on the call with us, and
Hello,
she'll be introducing our guest speaker. Cecily?
Okay, all right. So right before we get started, I just want to say that I'll be introducing the speaker here in one second, but we will have the presentation, which will last approximately about 30 minutes. And then afterwards, we will be opening it up for questions. We will be doing the questions via the chat only. So if you have questions, you can feel free to put them in the chat throughout, and we'll take notes. And then we'll also continue to take questions after the presentation is over. So let me go ahead and introduce our speaker. Tonight, we are very excited to welcome to our town hall in honor of Heart Health Month, a cardiologist. Dr. Arehzo Jahangiri is a board-certified physician in both internal medicine and cardiology. She's actually native to the DC area. She was born in Washington, DC, and grew up in Richmond, Virginia. And she did her undergraduate training also down in Richmond at Virginia Commonwealth University. She went on to do medical school training and her residency at VCU at the Medical College of Virginia campus and hospital. She then returned to the DC area to practice cardiology in a private practice at Anemia Heart and Vascular Center. Dr. Jahangiri's passion is in preventative cardiology, which is actually the prevention of heart disease. So she actually wants to prevent you from getting the diseases that will get you to go see her. She also enjoys aspects of cardiac imaging and also heart failure management. During her free time, Dr. Jahangiri enjoys spending time with her family, staying active by hiking, traveling, and rooting for the recently renamed football team, the Washington Commanders. I had to make sure I got that right because admittedly, I'm not a fan, so I probably shouldn't say that very loud. But without further ado, this is Dr. Arehzo Jahangiri and her presentation.
And if you do get one more interruption for you, if we do get questions along the way, feel free to just type them into the chat, and we'll get back to them when she's done with her presentation.
That sounds great. And thank you both for the opportunity to be part of this discussion with you guys and your patients. And I'm very excited and happy to be here on a very particularly interesting day. We were just talking about in preparation to talk to you guys. It's the 2/22/2022, so on a Tuesday, so lots of twos today, and so it's great to be with you guys. I'm very excited and to have a discussion with you guys about arrhythmias and palpitations, and try to figure out together when we should be concerned about it and when we should be doing a more extensive evaluation. So without further ado, I'm going to get started. And so my goals for our talk this evening is to go through a few important definitions so we make sure we're all on the same page, to talk about some causes of arrhythmias and palpitations and why they happen, how us as physicians evaluate the patient when patients come in and they have these complaints, and also how to manage. And at the end, like the doctor said, we're going to open it up to the questions, and we'll kind of go over them and address them and kind of take it from there. So I promise this is not a physiology lecture, but what I wanted to kind of start with is just to kind of get a little bit lay of the land and discuss about what it actually is an arrhythmia. So an arrhythmia is an abnormal rhythm. And so what happens is the body has these natural pacemaker cells in this top chamber of your heart called the SA node. And so what happens is a normal cardiac heart function, you have these cells that get activated and they send electrical signals down this natural highway of electricity in the heart, and they stimulate these muscles to contract. And they kind of create the squeeze that allows the heart to be pumped out of the right side of your heart to your lungs, and on the left side to your rest of your body and brain. And so in an arrhythmia, that's when this marching order gets chaotic. And so you have these random firings of these cells, and they cause these abnormal rhythms, and generally they are termed as an arrhythmia. And so an arrhythmia can be due to a slow heart rate, it can be due to a fast heart rate, it can be due to heart block, meaning that the top chamber and the bottom chamber, they don't talk to each other. It can be benign, meaning it's a normal part of our anatomy, or it can be something very scary and cause a sudden cardiac death. And it can cause palpitations. And so most of the time when we talk about palpitations as physicians, some patients are like, what are you talking about? What's a palpitation? And so palpitations are basically us being aware of these forceful, rapid, and these irregular heartbeats that can happen in our chest. And so our patients often describe them as fluttering in the chest, flip-flopping in the chest, butterflies, skipping a beat, and a lot of other ways that, it can be described, but those are the most common things that we hear. And it can be random. It can happen just for no reason. It can be regular. Why should you care about palpitations and arrhythmias in general? It's because sorry, there's an ambulance going by my house. No one's having a heart attack, but why should you care? Because most patients, I think they come to see us as physicians when they feel these palpitations, and it's sometimes accompanied by chest pain. They worry. They say, am I having a heart attack? Is this something really bad? Do I need to be worried? Do I have heart disease? And so I thought, I went and got some of this information from the CDC about the statistics of heart disease in our country. And so the leading cause of death, regardless of your race in America, unfortunately, is heart disease, which is why I'm very passionate about preventative heart disease, because a lot of these heart attacks and deaths can be prevented. But the statistics are really kind of astonishing. A person dies every 36 seconds from heart disease. That's heart attack, arrhythmias, stroke, those types of things. And according to the CDC, someone has a heart attack every 40 seconds. So maybe that ambulance that went just by was going to help somebody with a heart attack. But and of those people every year that have a heart attack, and you can see the statistics here, 600,000 of them are new heart attacks, meaning that they had no history of heart disease and they suddenly developed a heart attack. And some people are unfortunate and they have multiple heart attacks. And in some cases, we have patients that what we describe as silent heart attack, but patients that have this generally have very uncontrolled diabetes and a lot of other risk factors where they just don't feel the damage that happened to their heart. And so when we see our patients, we always kind of go through an evaluation and try to figure out what are some causes that cause these arrhythmias and palpitations. And so one thing is caffeine. So I'm not saying, your 1 or 2 cup of coffee a day can cause you to have palpitations. In some patients, it can if you have underlying heart disease. But if you're somebody that's on the go and your job's very busy and you drink a lot of coffee, caffeine, and caffeine gum supplements, eventually your heart's going to start kind of beating a little out of tune, and it's going to start racing because it's the same chemical that kind of activates the part of the heart that I showed you in the top chamber and makes it go fast. And so if you have too much of that circulating around, you're going to be feeling like your heart is racing, kind of jumping out of your chest if you have too much caffeine on board. Next is thyroid disorders. So, this is the thyroid gland. It sits right in front of your neck here, and it's a very small gland, but very critical in terms of a lot of functions in the body. And so if you have low thyroid or high thyroid, and predominantly in high thyroid cases where there's inflammation, the heart can beat very fast and in some cases cause the heart to get very weak. And, it can be a very critical emergency called thyroid storm. So as part of our evaluation, a lot of times we ask about your symptoms that may be associated with thyroid disease. And usually it involves checking your thyroid level as well. Next is anemia. And so anemia is when you have a low blood count and low hemoglobin, which are the oxygen carrying cells in our body. And so most patients that have anemia, they feel fatigue, they feel low energy, they feel short of breath and have chest pain because they just don't have enough blood cells circulating around to deliver that oxygen to the tissues. And as a result, what your heart does here, it's a very smart organ. What it does, it's okay, there's not enough oxygen being pushed around. And so I need to increase the heart rate to be able to move that oxygen around to all the tissues. And so as a result, if you have a severe anemia, you can feel your heart racing if it's, working overtime to kind of deliver that important oxygen to all your organs. Electrolyte disorders. And so our cells have a lot of electrolytes in them, and they kind of communicate with each other that way. So if you have some electrolyte disorders, either from lack of intake or some medications that your doctors may be giving you, you can have some arrhythmias because the electrical conduction in the heart very much depends on these important electrolytes that I've listed here. And it's not the calcium that you take for your osteoporosis, but in general, there's some conditions in the body that your electrolytes can get a little out of order and cause you to lose some of these electrolytes. And I've seen patients that have these low electrolytes, or in some cases high, have, again, certain arrhythmias that are very concerning. And, it's very important to be looked at as part of our evaluation. Medications, medications are used to treat certain types of palpitations and arrhythmias, but they can also cause palpitations and arrhythmias. So, those are your cold medicines, cough medicines, antihistamine, and decongestant. So if you have a bad cold and you take a lot of Claritin D or stuff that have a lot of decongestant, again, those medications are stimulants and they open up your blood vessels and your nasal passages, but they also stimulate your heart and they kind of make it go a little fast. Then you start feeling a little palpitation if you are using too much of it. Thyroid replacement. So if you are prescribed thyroid medicine and, we have to continuously watch that, because if we give you too much, you can start feeling some palpitations. Diet pills, again, they're stimulants, so they help you by burning fat, but they can also make your heart work harder. And in some cases of the, fen and those diet pills were taken off of the market for some related to that, but also related to it was causing a lot of valvular heart disease. So valvular heart disease in itself can make you have a lot of palpitations as well. Asthma inhalers. Not that people that have asthma and they use their inhalers because of, shortness of breath, they get palpitation. That's not what I'm trying to say. What I'm talking about here is the albuterol that we give our patients can also stimulate the heart to work faster and cause that. ADHD medications, again, the common theme is stimulants. They do cause you to have a faster heart rate. And this is, important. And I think sometimes we kind of brush against it and kind of go by this, but I feel like this picture kind of depicts a lot of important things that we all go through on a day-to-day basis, regardless of your profession and your gender and your race. And that can really make a big impact in your heart and your, if you feel your heart is racing, because again, when you have stress, your stress hormones get elevated. So you have a lot of these adrenaline and cortisol and these stress hormones circulating around, and they also, stimulate your heart to beat faster, because your heart is very smart, but it doesn't know what stress you're dealing with. So back in the day, if you were being chased by a bear or something, you would activate this system to make you run faster. And so when you have a lot of stress hormones circulating around, you do feel like your heart is racing or skipping a beat, because your heart is just trying to deal with the adrenaline and the cortisol and those types of things that are being circulated around. Substances, if you are a heavy smoker, it can create some changes in your heart and in your lungs, and those chamber enlargements can cause you to have fast heart rate. Cocaine just directly stimulates the heart to beat faster. Amphetamines, Alcohol, both the withdrawal and excess, can cause you to have palpitations and arrhythmias. And marijuana, which a lot of patients use to treat their stress, but and in some cases for pain management, but some of the additives that are in it can cause you to have palpitations. So it's very important to disclose if someone is using something like that, for us to know, to make sure that we address that and not miss something that is treatable. Hormonal changes. So as women, we go through a lot of different hormonal changes in our lifetime. And, I would add to this list of pregnancy, perimenopausal, and menstruation, birth control. I've seen some of my patients, they develop more palpitations around their menses. And then when they take certain new medications for their birth control, they do feel a little more palpitations. And we don't understand directly why that happens in terms of the pregnancy and the perimenopausal period, but just that influx and of hormones and withdrawal of the hormones, I think just makes it a stressful milieu and causes the heart to beat a little bit out of tune. Dehydration. We are a society on the go. And so I put this in here because I love The Office, but we're a society on the go and we don't drink enough water. We should be drinking about 64 ounces of water if we don't have heart failure, if we don't have kidney disease. And most of us, I'm guilty myself, we don't drink enough water as the day goes by. And so again, when you're dehydrated, your heart has to beat faster to kind of compensate for that lack of volume, and you do feel some palpitations as well. Poor sleep. If you have poor sleep from insomnia or pain, I know you guys just talked about that, or sleep apnea, which is a condition, it's a medical condition where you have an obstruction in the back of your throat, either from a large tongue, tonsil, or in case of severe obesity, then there are times at night where you're just not getting enough air through, and you do feel, these symptoms that are listed here: morning headaches, you feel tired, you feel like you need to take a lot of naps, and, those loud snoring and, periods of breathlessness at night can be a signal for that. And so let me move this a little bit so we can kind of see this a little bit better. But it's very important because it's very common, and it does have a lot of risk factors associated with it. High blood pressure, Afib, which we're going to talk about in a little bit, and heart failure can be a complication of untreated sleep apnea because it can put a lot of stress on your lungs, and the lungs get blood flow from the heart. And if they're not working properly, they put pressure on the right side of your heart, and the right side of your heart can develop hypertension and have problems. And so we always ask about sleep apnea when we have patients that see us for palpitations, and particularly Afib, which we're going to get into a little bit, because I think that's another thing that most people are concerned about, because they've had either a loved one or a friend that has had Afib, and when they feel palpitations, their concern is that they have Afib. So we'll get into that in a little bit. But how do we treat sleep apnea in general? It's a very treatable condition with some lifestyle modifications, and in some severe cases, you have to wear a mask at nighttime to help you breathe. And if it's something structural, like a big tonsil or something like that, then you can get surgery for that too. But it's very important to kind of make sure we ask about, how are you doing? How is your stress? Are you sleeping okay? When you do sleep, do you feel like you've had a restful sleep? And so you would, be surprised, because people look at me and say, why are you asking me about my sleep? I'm just here for my palpitations. But it's really important to kind of see if there's anything that's treatable to be able to treat it. And so this is where my kind of expertise and my think about these rhythm issues come in terms of when patients come in with palpitations to see me. These are the things, in addition to what I talked about, I'm looking for. And so it's the alphabet soup of cardiology. And this is the fanciest slide I have in terms of terminology. But basically, I try to explain it in a way that is easy to kind of communicate with you guys. So if the top chamber goes really fast, that's called an SVT. If it's the bottom chamber, it's VT. If it's irregular and chaotic, it's AFib. And then if PVCs are basically those skip beats that happen from the bottom chamber of the heart. And so AFib is a very common arrhythmia that we see in cardiology. And so it's, when the normal beating of the heart gets compromised and you have these chaotic, random, irregular beats that happen, and they can be dangerous because they can cause a lot of changes to your heart, but they also increase your risk of stroke. So some facts about AFib, which I thought was important for us to know, is that it's relatively common already, but it's estimated from the CDC to be increasing in number, unfortunately, because of the diabetes and the obesity pandemic that we have in this country. About 12.1 million people are estimated to have AFib by the year 2030. Patients of European descent are more likely to have AFib. And I tell my patients when I see them for AFib that it's a disease of the aging heart. So as we get older, the electrical system in our heart ages with us. And so patients do get more arrhythmias as they get older. And women live longer, and women tend to get more AFib and tend to have a lot of complications as a result when they do have AFib. So some of you may have seen these maps before, and they kind of mimic a lot of the same things in terms of risk factors. So this one specifically is about dysrhythmias like AFib and stuff like that I just talked about. And you can see this kind of eastern part of the eastern, southwest, and south and northeast, and is much more at risk of having arrhythmias compared to our western part of the country. And the reason for that is if we superimpose basically the obesity map and the diabetes map, it's the same area that lights up. And so unfortunately, there's just much more diabetes in this area, as well as obesity. And that kind of goes hand in hand with AFib. So what are the risk factors for AFib? So we talked about one, which is advancing age. High blood pressure over time can cause some AFib in some patients. We talked about, race and obesity, diabetes, heart failure. When your heart gets weak and the chambers enlarge, you are at an increased risk of an arrhythmia called AFib. Ischemic heart disease is a fancy way of saying having heart disease as a result of a heart attack or blockages. Hyperthyroidism, which we talked about already, which is your thyroid is high, kidney disease, alcohol use, and chamber enlargements on the left side of the heart. Does this mean if you have any of these, you're automatically going to get AFib? No, but when we do see patients that have AFib, we see that a lot in them. So how is AFib related to stroke? So strokes happen for two reasons. Either you developed enough plaque or cholesterol buildup in the arteries of your brain and the blood flow gets compromised, or a plaque just ruptures and goes to your brain. And when that happens, people develop, unfortunately, a stroke. So when patients have AFib, it increases the risk of clot formation because that chaotic heartbeat doesn't let the blood flow in a smooth fashion. And so as a result, in the nooks and crannies of your heart, patients can develop clots that unfortunately can go to the bottom chamber and go to the brain and cause problems. And so it's, AFib causes 1 out of 7 strokes. So it's not a small number. And so as cardiologists, we are always looking for this when you come to see us, and your doctors, when we're all talking to you, we would be doing an EKG and stuff like that to look for that specifically, because A, we can treat it, but B, also you need to be on some important medications about risk reduction. So how is it treated? When we do see AFib, we give you medicines to help control your heart rhythm and rate. We put you on some medications that are called blood thinners to help reduce the risk of clot formations, and by that, reduce your risk of having a stroke. And those are Coumadin, warfarin, Eliquis, Xarelto. There's surgeries in some cases where it's not treated with medicine called an ablation. And also if you have a persistently fast rhythm, we can do a cardioversion. And I do that at our office. And so, but like not in our office, but I'm the cardiologist at our office that does it. And then also medicine and lifestyle changes, which is at the bottom, but is very important because the lifestyle changes like treating your blood pressure, losing weight, if you have sleep apnea, to get that treated will really dramatically reduce your risk of having heart issues and stroke from your Afib, and reduces your Afib burden. This is a little plug about our social media. And so we have a great student that is now going to be leaving us and joining UMD to become a doctor. And so she makes these very nice animations and videos about A-flutter, which is very similar to Afib. And so she goes through and kind of gives a very nice information about what it is and what things are. And she's very talented with her drawings, and we're sad to see her leave, and I think she's going to do big things. But the links to all of these is on our Twitter or Instagram page. And so if you go to that and follow us, we do put a lot of videos similar to this on there, a lot of information about different types of educational tools for patients to be able to learn a little bit more about heart disease and stuff like that. So if you're interested, follow us, and you'll be able to learn a little some information about us. So when should you see your doctor about palpitations? So if you feel them and they're just increasing in frequency, and you have risk factors for heart disease like high blood pressure, diabetes, high cholesterol, a heart rate at rest of over 100 where you're not doing anything generally is not normal. So if you do see that, then definitely you need to talk to your doctor about that. If your palpitations or the heart racing is accompanied by chest pain or trouble breathing, if you fainted from it, it's never normal to have palpitations and faint. So you should definitely see a doctor. If you feel lightheaded or dizzy while you get these palpitations and you feel like you're going to pass out, you should see your doctor. If you don't know what this is and you want to know what it is and want to make sure it's not anything serious, you should see your doctor. Okay. So, but these are some very important things to be on the lookout if you do have palpitations or feel like your heart is racing. So generally, what do we do as doctors when we see you in our clinic? We always get a very good and thorough history and physical. So with the history, we're all going to be thinking about those causes that we talked about earlier. We're going to ask you questions about your sleep, your things that put you at risk for thyroid disease, if you've had blood loss, like a lot of questions. And also we're going to be listening to your heart and lungs, listening to make sure there's no valvular disease, there's no excessive fluid buildup in your lungs that point to maybe your heart having issues. And so we're going to be collecting a lot of information to try to figure out exactly what's happening. So then after we do that, most of us do an EKG. We want to see what the rhythm is, what's going on. And for those of you that haven't had an EKG, which there will be a very few of you, they just put electrodes on your chest and your arms and legs. And then we get a tracing, we look at it and see if the rhythm is normal, if it's abnormal, if it's too slow, too fast, and kind of figure out what's going on there. If generally, if we hear a murmur or we see an abnormal EKG, it's usually followed up by doing an ultrasound of the heart. Generally, we don't do the ultrasound in a suit. I just thought this picture was funny because this person's very nicely dressed doing an ultrasound, which is great. But so if you see us in scrubs, or our technicians in scrubs, which are generally the team that does the imaging, don't think they're doing subpar job or they took a day off. But basically what we're looking at once the imaging is obtained by our technicians, we're looking at your heart function, looking for structural issues with your heart that may explain the palpitations, making sure that the pumping function of your heart is nice and strong, and that there's no abnormalities in the valves of your heart. And a lot of times, if both of those things are not revealing, but we're concerned that there is still a rhythm issue, but we're just not catching it on that 10 EKG, which only captures 10 seconds of your heartbeat, then we decide to put you on a monitor. either a Holter monitor, which is on the left over here, where you go home with this Walkman thing with leads, and all it's doing is it's recording your heart rate for 24 hours and sometimes 48 hours, and it's continuous. You can't take it off, and what we're looking for is your heart going too slow, too fast, and trying to figure out what's going on there. And if you're having these skipped beats, if they're happening at a large number, or if they're just happening, randomly or rare, then we don't usually treat it. But if you do have a lot of these early beats that come from the bottom part of your heart that make you feel like your heart is skipping a beat, over time, if you have a high percentage of it, it can actually weaken your heart. So we always screen for that. And this is very helpful if somebody's having symptoms every day. Most patients don't. And so when they don't have symptoms every day, then we put something on them called an event monitor. So an event monitor is does all the things a Holter monitor does. It records your heart rate. It is able to detect arrhythmias. It can do that on its own without being prompted. But what's additionally important and helpful from the event monitor, I tell my patients, it creates an on-demand EKG for me. And what do I mean by that? Is when you have a palpitation or you feel like your heart is racing, it comes with a journal, but also there's a button on the device here that you can press, and it creates a snapshot of your rhythm at that same time. And it will come to me as a file. It's not a live transmission. And then what I do is I review it, and I look and see at that time when you pressed it if there was a rhythm issue. Generally, if there is a rhythm issue and it correlates with it, and it's a abnormal rhythm, then we treat it. But sometimes it's helpful for me to talk to my patients, and if they pressed it and the rhythm was normal, then what they felt in their chest in terms of the palpitation was less likely to be related to the heart. And that sometimes gives patients a lot of reassurance, but importantly myself too, because I don't want to miss some sort of arrhythmia like VT, where it comes from the bottom chamber, that can increase your risk of sudden cardiac death. So we generally can have patients wear this up to 14 days. And, patients can shower with it and do their day-to-day activity with it. But it's not a live transmission. There is another version of this, which is similar. It's a cross between this one and this one, where patients wear it. It's called an MCT monitor, and that is a live transmission. So we usually put those on patients that had a fainting episode that we think came from a rhythm issue with the heart. And so we usually reserve that for those types of patients, and it's very helpful. And we have found significant arrhythmias with that and been able to help patients and save their lives, and, make sure that they don't have something bad happen to them from having a low heart rate. So then I always get this question from my consultation from my patients: what about an Apple Watch? What about a Fitbit? What about a Garmin? What about something else that just came on the market? What are your thoughts, doctor? And so I think, I found this on Circulation, which is a publication in cardiology. And so the first bullet, it talks about the Apple Heart Study, which was a study done in Cleveland Clinic, which is if you don't know, it's a very prestigious hospital for cardiology. And so what they saw was that if the Apple Watch alerted the patients that they had an arrhythmia, 34% of the time they actually did. So it's okay, I guess, for lack of a better word. But in their own internal study, they said that if they classified the ECG that came from it as sinus rhythm or Afib or inconclusive, they had a high sensitivity and specificity, meaning that it was very accurate. So I think it falls somewhere in between. In my personal experience, I have seen patients that have worn the watch, and they bring me the 1 lead EKG as a PDF, because the newer versions can make a PDF. And I learned that the hard way, because I bought one of these from my husband, and then the first 24 hours he was sending me like an EKG every hour. So it does do a PDF. And so in some cases, I've actually seen it correlate very well, with especially PVCs, which are the bottom arrhythmias that happen, the skipped heartbeats. And so I think it's not a bad idea to have one? Do I suggest all my patients get one because they want to see what's happening with their rhythm? Probably not. And full disclosure, I have no association with any of these things that I'm telling you about in terms of devices. And so Cardia Mobile is another thing that also comes up for our discussions, because people talk to their friend and they're like, oh, I have this thing my cardiologist told me to get. And, you know, it creates a lot of questions for us. And Cardia Mobile is a paid subscription that you can get on the App Store, and it comes with the device here that you see that they're using, where you can put your 2 fingers on there, and it will create a 1 lead EKG for us. And again, this has the ability to create a PDF. And I think this is also a good tool to have for select population. I think some patients like to know about a lot of they would like to check their blood pressure. So I think for those people that really want to know how their body's performing, it's a good tool to have. And so you can look that up and see if it's within your budget, but I wouldn't recommend it to like everybody to get it. They're generally in my office because it can be a little expensive because it has like a $10 a month membership, and the app itself, the first initial download is about $80. But the patients that I do recommend for is, you know, my patients that have a lot of Afib and they don't know what's going on. Sometimes when they feel something, this can be helpful for them to check it really quick, give them some reassurance. And if they are back into Afib and they're very symptomatic, then we can try to help them out. But in general, like, I don't recommend people getting this and like putting it in their medicine cabinet or something like that. So in terms of treatment, the treatment's generally pretty straightforward. And what do I mean by that? So most palpitations are benign, meaning they're not serious in a sense that they're causing you harm. They may be causing you on feeling a discomfort and stress, but they're not serious in a sense that at the beginning we talked about, you know, patients always worry if they have AFib or if they're about to have a heart attack. So most of the time we treat the underlying cause. So if it's related to thyroid, we treat the thyroid. If it's related to anemia, we treat that. If it's related to a rhythm issue, then you come see me basically. So, you know, if there's anything that, you know, it's related to sleep apnea, we treat that. And so the medications generally for rhythm issues are beta blockers or calcium channel blockers, which they just help regulate your heart rate and kind of stabilize it. And these are our locations, and you know, we'd be happy to see you if you have any questions. But generally, I tell my patients, you know, they usually see their primary care doctor first, get evaluated by them. They're basically wonderful and they know about all of these things, so they can screen you. And then if they have concern that your palpitations are cardiac in nature, then you can come see us. You can see any cardiologist. But I generally tell my patients it's better to be proactive and speak up if you feel something and have it not be anything serious than to continue to live with something and then you come in and at that point we may have had some damage to the heart valves, to the heart function. And so it's always important to keep an open conversation with your physician that you're seeing in your family medicine, internal medicine practice, or your physician assistant or nurse practitioner, whoever is your primary provider, to make sure that your heart's, you know, in good shape if you do feel something like this, that your heart is racing. And then if you get screened by them and there's some concern, then, you know, we're always happy to see you and provide some extra assistance. I always try to give my patients resources and they always like want to learn more. So the American Heart Association has a nice website called it's very original, heart.org. And so there's this tab here that I took a screenshot for you guys. If you go and just hover over it, and it gives you health topics, and there is a plethora of wonderful information there for you. That is some of the information I was able to, for today's presentation, to get from there. But, you know, if you are interested in learning about, you know, sleep apnea, like we talked about a little bit, AFib, heart attack, blood pressure issues, heart failure, strokes, a lot of stuff, and arrhythmias, like we talked about at the beginning, this would be a good place to start and kind of get some information and see if what you're feeling is something that needs to be evaluated. And they have really nice animations and stuff like that that can help you get more informed and be a better advocate for yourself and your health. And at this time, I'd like to thank the Northern Virginia Family Practice, especially Dr. Havert and Beauvais, and the other providers and staff, and you wonderful patients for listening to me, and hopefully this was helpful.
Thanks, Dr. Jahangiri. So great to hear from you. And I'm really glad we have 20 minutes for questions. I'm sure that Dr. Havert and I can come up with our own, but we'll start with our patients' questions.
Sounds wonderful.
And so anyone who has a question as we're talking, feel free to put those either in the Q&A or in the chat. Here's a good question. Why do some people with Afib get pacemakers and some others don't? And maybe another question alongside that would just be, why do people get pacemakers?
Okay, great question. And so a pacemaker, we generally put that in if someone's heart rate is too slow. And that's where there's a miscommunication with the top or the bottom chamber. Patients get sometimes Afib, and generally it's fast, but in some cases the Afib can be slow. So in some patients, they get a pacemaker because their Afib is too slow. But in some cases, patients with Afib, their heart rate gets so fast that to treat it, we have to do either certain procedures like I talked about earlier, which is an ablation, or increase their medications. And generally, if we have to do an ablation where we disconnect the top and bottom chamber from each other with localized treatment to the area, then those patients will need a pacemaker because we've kind of disrupted that highway to help kind of take out the chaotic beating in the top and kind of give a new marching order with an external pacemaker to those bottom chambers. So generally, not everybody that gets Afib needs a pacemaker, except in extreme cases where it's really slow, or we just want to kind of take over the pacemaker cells in the heart and just put in a pacemaker because we can't control the Afib. It's just so out of control.
Mm-hmm. And people feel so much better when they have a slow heart rate and they get a pacemaker. They leave your office so happy.
Yes, for sure.
More energy again. Question about myocarditis. And this is about the COVID vaccine, and also probably I'd love to hear you comment on COVID itself and other things that cause myocarditis. This question is, we've heard that COVID can cause myocarditis, and it is a 133-time risk factor with the mRNA vaccines. I'm not sure the data myself about that number, but could you tell us a little bit about myocarditis, myocarditis with any virus, with COVID virus, and then maybe with the vaccines in comparison?
Okay, wonderful question. And so I didn't put a lot of information about COVID as itself causing arrhythmias, and also because it's, I think, a topic on itself. And so what I would say about the myocarditis risk of Afib is, myocarditis risk from the vaccine is myocarditis basically is a way of saying having a fast heart rate, inflammation in the heart. And so that happens as a result of, like Dr. Beauvais said, certain viral infections. And also, before COVID, there was viral infections like Coxsackie, common cold, influenza. Those things, sometimes the inflammation can be so strong, it can affect the heart muscles in addition to like your respiratory tract, and it can cause inflammation. So that's what myocarditis is. So when you have myocarditis, and it's a very rare complication of the actual coronavirus infection, and in some patients, there has been some evidence of them getting the vaccine and developing this inflammation. And so when they do have this, the patients feel chest pain, they feel palpitations. And more recently, I've had some of my patients come in after the booster vaccine saying that they feel a little bit more palpitations. And so after the vaccination, the vaccine is giving you an inflammatory response because it's trying to help you develop antibodies. And so in some patients, that inflammation that happens as part of developing the antibodies can make you feel a little bit of palpitations because your body's trying to get strong and develop those antibodies. That's normal and usually subsides within 6 weeks, according to the articles that I've read. I'm not sure about the number your patient quoted, but there has been an association, particularly in young male patients, with myocarditis from the vaccine. And we don't know who is at risk and why they get it, but it's an extremely small number. When they did the study, in terms of the millions of people that have had it, it's a very low percentage of patients that get the myocarditis from the vaccine. And so generally, it's short-lived and there's not a lot of damage to the heart, and patients do relatively well if they're treated through the inflammation, and the function usually recovers. But myocarditis is not, I guess it is rare complication of the infection and the vaccine, but a very treatable one. But it does cause, if you have a very severe case of myocarditis, which is more common in the other viruses, you can get the arrhythmia called VT from the bottom chamber of your heart, and that can unfortunately be deadly in some patients. But there hasn't been a lot of documented cases of VT caused by the COVID vaccine and the COVID virus. I hope that answered their question.
Yeah, I think that's helpful. I think another thing I would reflect on in terms of just some of the medical data is that I can't comment on this particular statistic, but I have had patients bring in questions where I said, hey, I read this, and is this really 100 times more likely to happen in this case? And if you really look very, very, very carefully at what they're saying, the statement is accurate, but they're talking about something that only happens probably 2 in a million times. And so if it's 100 times more likely to happen, it's still a very rare event. So we don't know the answer to that question about the number itself.
Mm-hmm.
Cecily, do you want to ask any of these questions?
Yeah, I was going to go ahead. Why don't I pop over here? This question is coming in. Why can AFib reoccur even given all the medications? I guess these are the anti-arrhythmia medications and procedures such as ablation that are available today. And why is AFib controlled and not cured? I think that's sort of an interesting way to look at it. But I guess this is sort of looking at, we try to control AFib. Sometimes we throw medications at it, and the AFib comes back. And I've had patients go for cardioversions, and it doesn't last. Even ablations, sometimes it'll come back. So can you explain why maybe AFib is sort of a tricky rhythm to try to control? And is there any way to really cure it? And I think I know what you're going to say about the curing part, but can you talk about the control part too?
Okay, so I'll answer the easy one first. So AFib is unfortunately a chronic disease. It cannot be cured the same way we treat other conditions that are very curable. And so it's very manageable, but the question is very astute in the sense that there are times where we have people have recurrence of their AFib. And so generally AFib, your patient mentioned ablation. Ablation is not 100% curative. So in the best hand and the trained electrophysiologists, which are cardiologists that specialize in rhythm, they do have the patients, if they're very skilled, about 90% of the time they get cured. But what we have to also understand about AFib that recurs is what was the substrate of that patient. And what do I mean by that? So that patient, we have to look at their heart anatomy. So if you were a patient that had AFib because your chambers were very enlarged, you had uncontrolled hypertension for many years, we're not able to change the underlying pathology that's in the heart, which is the enlarged left atrium or that top chamber. And when they go to do the ablation, they're in that top chamber finding these focuses and, applying treatment to it. And hopefully they can wall off most of it. But in some cases, there's so much AFib that they may not get all of it. And so it does recur, especially in a patient that has a very enlarged left atrium, which is the top chamber, where the veins from the lungs come in, and that's usually the area where they have to go and kind of take care of. And it happens in patients that have untreated sleep apnea. So if you're a patient that's obese and you have AFib and you didn't have your sleep apnea treated, there are multiple studies that show that that increases your recurrence. If you are a patient that developed a new problem, where your heart needed to go faster and just the AFib focus was more active, then that can come back. And so, yeah, cardioversion, which is also what your patient mentioned too, is in some patients, they do one cardioversion and they get on medicines to control their blood pressure, heart rate. They don't have any other risk factors for AFib, then they do well. And so it varies by case, but in general, when patients go for an ablation, most cardiologists do tell them that it's not 100% curative. We can help abate the symptoms of patients a lot because they're very symptomatic, some patients. And some patients walk into my clinic and they're like, yeah, I went for my physical and they did an EKG and I'm in AFib. And the reason is that the nerves around your heart are not the same and sensitive as the nerves around your fingertips. So what happens is, because you don't want to feel every heartbeat, you don't want to feel the food moving down your esophagus. So the nerve endings in that area are very variable. So some people have they're more in tune and they're more aware of those nerves, so they feel the AFib and they feel the palpitation more than somebody that may be having skipped heartbeats. When we listen to them on the exam and you do the EKG, you're like, they're in AFib, and they're like, are you okay? And then he's like, yeah, what are you talking about? So not everybody is, basically, for lack of a better word, made the same way. So these patients do have AFib and they don't feel it. And so for those patients, they may not go to ablation, they may just have the rate controlled. But in some of the other patients that have AFib that very symptomatic and we maximize medical therapy, then the next option is the ablation or cardioversion, with our aim to be successful. But unfortunately, it's a chronic disease and it comes back, and we don't really, the reasons I mentioned are the most common reasons. And sometimes it happens and we've done everything right and the patient's done everything right and we just don't know why it comes back.
Yeah, it's a complicated it's a complicated rhythm, and again, no two people are the same, and so I feel and I find that it's very individualized for what people need. But I think one of the biggest risks for AFib, I think, is the stroke risk. So that's what I find that we're definitely focusing in on and trying to prevent that secondary complication. So. Another quick question. I think you alluded earlier to certain electrolyte abnormalities that can cause palpitations or different arrhythmias. And this person is asking if there's a blood test to check for electrolyte disorders. And yeah, I mean, I can probably answer this one, because I think if you come in for your physical every year, all of those electrolytes are being checked. That's part of it. The basic metabolic, or actually we do a comprehensive metabolic panel. So that's something that is checked regularly. I don't know if there's anything else you want to add to that, Dr. Jahangiri.
No, generally, the labs that Dr. Havert said, that includes most of the electrolytes. I think if I had a patient that was on certain medications like diuretics, I would also throw in a magnesium in there, which is not always in the panels, depending on the lab that you send it to. But generally, when you're getting your physical and you're seeing someone for palpitations, they will definitely be checking that, along with the blood count and your thyroid, most likely, depending on what your symptoms are.
Can I ask a question, or just kind of share an experience? I think we have a lot in primary care, which is so many people come in, fortunately, they come in just like what you're saying. They have some kind of a concern, they feel something, they want us to check it out for them. And quite often we have to really take a history to determine if this is something that we want to have a workup on. Do we want some cardiology support here? Or do we feel very reassured that the type of experience they're having is normal? within a normal variant. And so I wonder if you could talk about how you handle that question when somebody comes in and it's a natural part of your own history taking.
Yeah.
And what are the reassuring things for you when people come in, and what are things that would kind of give you a pause?
Good question, Dr. Beauvais. In terms of your first question, my job as a specialist a lot of times is not as hard as the primary care doctor, because you guys do a fantastic job of ruling out the scary stuff before patients come to me. So you guys are checking the EKG, you're checking the electrolytes, you're checking if they need any type of treatment for their anxiety, if they're doing, substances, you work with them about that. But when patients come to me, I go through the causes that we went through, and just, because sometimes things can get missed and patients may not say certain things to certain providers. And so I kind of go over the questions again and I do my own assessment in terms of the questions. And then the things that I pay close attention to is the timing and what is happening to patients when they feel that their heart is racing. If they say, if they usually patients start off by saying, yeah, I feel palpitations, it happens every once in a while. I'm like, what are you doing when it's happening? Because that's a very important thing to kind of help me differentiate. Is this, for lack of a better word, a scary rhythm, or is this something that is probably a benign ectopy or a benign rhythm? And so generally, if the patients say that my heart is skipping a beat and it has or it's racing, if they say my heart is racing, it races really fast and it comes down really fast, then that's usually most likely an arrhythmia. If they can feel it and they felt their pulse in their hand, in their arm, or in their neck, that's usually an arrhythmia from the top chamber of the heart, where it has a quick on and quick off. And so my threshold for an arrhythmia goes up higher. If they describe the palpitation in the setting of stress or grieving or something like that, I think of more of the low level arrhythmias like PVCs and PACs. If I have somebody that says they feel their heart race and then their vision goes a little bit and they feel lightheaded, or if they've had passing out episode with it, that gets my attention very much, because cardiac arrhythmias usually cause, if they're very fast or too slow, the heart's not either pumping blood fast enough or to the brain, people can pass out from it or feel lightheaded. And then if they pass out, that usually means that they had what we call syncope. And so syncope is when you lose consciousness and you lose postural tone, meaning you fall to the ground or lose control of your body. And so when I hear that accompanied by a patient saying my heart was beating really fast, and then I worry about arrhythmias that can be very detrimental. However, those are rare. And then if someone says I have a family history of my family dying really young, those are certain types of cardiomyopathies like HCM, or other types of cardiomyopathies where it happens in younger patients and they die suddenly because of that arrhythmia. And so if they have a murmur, that increases my likelihood of having a cardiac arrhythmia. So in general, it's a combination of the symptoms and the physical exam that I see that kind of guides me to kind of decide what type of additional testing I want to do, and then how concerned I am about this patient and which type of testing I want to do in terms of the monitor. If I think they passed out because they had a VT, which increases your risk of sudden cardiac death, or like a slow heart rate that makes you need a pacemaker, then those people are getting that live monitor and probably an echo on the same day before they leave the office, because I don't want them to drive home and have a problem. And so generally, I pay close attention to those patients.
I think what I heard from all of that was that actually taking a good history, I think, is probably one of the key parts. And so I don't think we expect necessarily people to be like to know necessarily, well, this heart rhythm is a bad one, this is a good one. I think what you can take away from that is just to trust that your medical provider has the training to be able to delineate that. And so, and there's a question here also about addressing, and this is not necessarily about arrhythmias, but differentiating between heart and GI pain. And I think the big takeaway there is, go and talk to your doctor. And the history that we take, we're like detectives, right? And so we'll ask very specific questions that will tell us that'll kind of kick certain things off the list and put certain things up high. So, there's certain keys that will tell us. But I think the bottom line is that, just, trust your doctor. And when you go and see them, that this is a process that we're going to help you understand, right?
Yeah, and the part that you mentioned about the GI tract and the heart is very important because the heart sits in front of your swallowing pipe in terms of anatomy. And so if you have really bad reflux or have really bad GI disease or something like that, your heart, because it sits in the front, you feel it here in the middle of your chest. And so again, because the nerves directly don't go and say this is the heart and that's the esophagus, you do feel just like something hurts in the middle, and that's all you can tell me. And that's a lot of times that people come in and see me and they're like, it just hurts here. I don't know how to describe it. It hurts. What does it feel like? Because to us as physicians, it makes a difference how you describe your chest pain. But sometimes you can't describe it, and that's okay. That's our job to figure it out. But the GI tract can sometimes be a little bit confusing for both the patient and us. And, if you do have some of the history, like Dr. Havert was saying, that lead us more towards reflux, then we may elect to treat that first before we do more of a cardiac evaluation.
And one more quick question here. We're running out of time here. This is somewhat related also. What about low dose aspirin? I know that recommendations have recently changed on that, but I guess we're not recommending that everybody go on low dose aspirin anymore, correct?
That is correct. And so, the teaching was, I had an attending that said, people turn 50, we say happy birthday and give them an aspirin. And so we've definitely shifted our views from that. And the reason is, patients get frustrated. It's like, well, why didn't you know that before? And why did you tell me to do that? And now, now you're telling me to do something different. And the reason is we're living longer. Compared to, 20, 30 years ago. We did have a drop in the life expectancy this past 2 years, but we are living longer. So, we have people living now well into their 90s and having a full life. And so that teaching was, as they've done more study, they showed that it doesn't really help prevent your risk of stroke or heart attack if you haven't had a heart attack. So I really wish that when that article came out, it was like a big, I'm sure at your office too, everyone's like, I'm coming off my aspirin, thank you so much. And you're like, no, please don't do that because you have heart disease. And so if you don't have documented heart disease and stroke, then you don't need to be on aspirin. And the reason is that, in certain cases, it's again, guidelines are supposed to guide physicians, they're not concrete. So based on your doctor's discretion, you may need to be on aspirin, even if you don't have those. But in general, you don't need to be on aspirin because people were living to like 80s and 90s, and it was just increasing their risk of having GI bleeds from the aspirin. And because as we get older, the stomach linings and the intestinal linings get thinner. So the aspirin can cause you to have much more easier bleeding. And so they said that, you have to have a discussion with your physician and kind of revisit that and really make sure you really need to be on the aspirin. But most people in my office, they really do need to be on aspirin. But in the primary side of things, it's a discussion you have to have with your doctors and your providers about should you be on aspirin, going forward. I think it's an important and interesting topic, but the aspirin is not recommended anymore. Like even they did studies with colon cancer because they had some evidence that it was helping with colon cancer, and that ended up not being as robust of data as they thought it was in the past.
Yep. So the science keeps changing as I think we always learn and
more, right?
Yeah. I know, especially these last 2 years, you wait a week and something new comes out. So
yes, it was a sharp learning curve for sure.
Exactly. Well, I don't want to keep people too much longer here, so I think we can wrap up. Dr. Beauvais, do you want to wrap us up and tell us about the next presentation?
Sure. Well, Arehzo, thank you so much. And we really, really appreciate it when you get our patients in like same day, next day when we do have
Anytime.
something.
It's our pleasure. You know, we always recognize that, you know, you guys wouldn't send them if you weren't concerned. So we always don't want to turn away patients when another doctor says they need help. We're there to help you guys out.
Yeah, well, we really, really appreciate it. And we really couldn't treat everybody without the collaboration of cardiologists. So we appreciate you being here and doing good work.
It was my pleasure. It was very nice to talk to everybody. I hope everybody got something out of it.
And for those of you who don't want to see a cardiologist, we're going to have Dr. Ken Zweig, your favorite media physician from NVFP. We usually keep him to 3-minute videos when he's giving the COVID updates, which you get on your cell phones. But next month, he'll be giving a talk on behavior change, and he will be the speaker for this town hall. And if you're hoping to change some behavior this year and improve your health in that way, then tune in.
Awesome.
Okay. All right. Well, thank you so much once again, everybody, for joining us, and we will see you next time next month for the town hall. And I believe the date for that next town hall will be March the 16th, which is a Wednesday. So just keep an eye on the announcements, and we'll send you that information when it becomes concrete.
I'll actually put in one more plug, which is that Dr. Havert and I are currently working on becoming podcasters. We have not yet published a podcast, but we hope to have some for you in the next couple months, and we'll give you updates along the way, interviewing other physicians in the community about their experience in medicine.
Awesome.
Stay tuned for that.
Stay tuned, yeah. All right, great to see you, everyone.
Okay. Good night, everybody.
Good evening.
Nice to meet you. Bye.
Bye-bye.